So a lot of times patients come to see me and they know that something's wrong with their rotator cuff. Oftentimes they call it their rotator cuff, but it's actually cuff, and it gets its name because it's actually a cuff of tissues that surrounds the ball of the ball and socket joint. And it sits like a sock on a trailer hitch. And shoulder mechanics are pretty complicated. You really have the interplay of a lot of muscles. You have the muscles that attach to your shoulder blade, and then you have the muscles that I said, the rotator cuff, that attach to the ball on the ball of the trailer hitch. Those muscles pull the ball into the socket, and then the big muscles that we all know about, like the deltoid, the pectoralis, it will move that shoulder. So what happens when the rotator cuff becomes deficient, whether that's through an injury or overuse or different weird mechanical issues, it becomes painful, and people will usually describe the pain along their arm out to the side. It's typically worse when they're reaching overhead. Those are all the big kind of red flags. Night pain is a red flag for maybe either having a rotator cuff tear or some sort of lesser pathology like bursitis or impingement. All these are complicated terms, but they're all terms that are related to the rotator cuff. So how do we treat it? We treat the rotator cuff pathology depending on whether there's a tear or whether there's more of a bursitis, which I call a pre-tear. And typically we do that with anti-inflammatories, or we might do that with injection therapy. And usually there's a component of either a home exercise program and physical therapy. But one of the first things we do is we try to identify what's the actual problem. So typically an appointment might start with x-rays, obviously a history from the patient, a physical exam, and then once we've made a determination as to what the condition of the rotator cuff is, then we can make a determination on what's the best treatment course.